Hello, Dr. Bruck. Thank you very much for allowing us to interview you.
My pleasure. Thanks for being here.
I wanted to start with define for our viewers the term urologist. It's not, people don't, they talk about going to the doctor, and they don't often specify or understand the specialties.
As urologists, we treat problems in the genitourinary tract. So we deal with problems in the kidneys, bladder problems, prostate problems, and problems of the genitalia for both men and women. As urologists, we have a unique role, being that we are both medical physicians as well as surgeons. We're surgeons. In other parts of the body, say in the heart, you have a cardiologist who is a medical doctor for the heart, and then you have the cardiac surgeon who is the surgeon for the heart. We perform both roles in the genitourinary tract. You have a nephrologist who's a medical doctor for the kidneys. However, there's no medical doctor for the bladder, the prostate, and the genitalia. The main problems we deal with, the majority of our patients are older men who have urinary tract problems, such as prostate problems, urinary symptoms due to changes in their prostate. We deal with kidney stones. In terms of our female patients, we deal with women who have urinary infections, chronic urinary infections, overactive bladder problems, urinary incontinence. We also, we're oncologists as well, so we deal with cancers in the urinary tract, most commonly prostate cancer. We treat prostate cancer through a number of different treatments, including surgery. We also deal with kidney cancer, bladder cancer, testicular cancer, and some of the more rare cancers in the urinary tract.
And in dealing, you specify you also deal with women. I'd like you to talk about that just for a minute, because often when people think of urologists, when they do understand the term, they also are limited. They think you're a man's doctor.
Indeed, I think there is this sense that we are gentlemen's doctors, or we are a man's doctor. If you come and sit in our waiting room, you'll probably notice about 20, probably 30% of our patients are women. Women definitely have problems in the urinary tract, most commonly overactive bladder. That's a very common problem. Over 30 million people in America have overactive bladder. The majority of those are women. Women also get kidney stones. They also deal with urinary incontinence. They also do get cancers in the urinary tract, such as kidney tumors and bladder tumors. So we do see a fair number of female patients. Very often, gynecologists or primary care physicians will deal with simple urinary infections. When things are a bit more complicated, that's when the female patients will be referred over to us.
Urologist, yes.
Sure.
And so when we're talking about, let's talk about men and prostate cancer. I've been told by doctors that if a man lives long enough, he will eventually every man will get prostate cancer if he lives long enough. Is that true?
There was a study performed years ago, a very well-performed study, where autopsies were performed on men at age 80. And these were men who died of multiple causes. None of them had a diagnosis of prostate cancer at the time of their death. And when they did biopsies on the prostates of all of these men, they found microscopic evidence of prostate cancer in about 80% of those men. Which tells us if you do a biopsy on every man 80 years old in the community, you're going to find at least microscopic prostate cancer. I think it almost is inevitable that all men at some point will develop at least some microscopic prostate cancer, especially if they're living into their 90s and beyond. And believe it or not, we have patients well into their 90s, and have several patients who have reached the age of 100. The question is, when is this cancer a clinically significant cancer? Meaning, when is this cancer going to become a problem for a man? And that's not always an easy answer. There's not always an easy answer to that question. And that's where we have to treat patients on an individual basis. You can't say, just because a man has prostate cancer, he needs this treatment. You have to look at his prostate cancer, and every prostate cancer is different. The biology of each man's prostate cancer is different. Some men have a more aggressive, more high-grade type of prostate cancer. That's a type of cancer that for sure needs treatment to prevent that cancer from becoming a problematic tumor, to prevent the man from ending up with metastatic disease or distant disease away from the prostate. Some older men who have very early, very low-grade, non-aggressive prostate cancer might be candidates for what's called observation or watchful waiting, where instead of treatment, we just watch their cancer over time to ensure that it does not become a problem for them.
Yeah. And I want to ask you about that because in the Caribbean, many of the islands are culturally British, let's put it that way.
Sure.
And in Britain, my experience of what I understand is a lot of it, they tend to do the observation. They tend to do observation more than anything else. And I've actually heard in conversation, politicians and men talking about it and decided whether it's a good idea or not.
This is
as opposed to the American, what they think is the American idea of.
This is an ongoing debate in America as well. This is a debate. It's a discussion that we, as a medical community, as a urologic community, we're continuing this debate all the time. Recently, here in America, the United States Task Force on Preventative Medicine came out with some shocking recommendation to a lot of us. They recommended that we don't use PSA any longer for screening in prostate cancer, which is it's a very controversial recommendation. The truth is that PSA still helps us to detect early prostate cancer. There is a sentiment in the medical community in America that we're overdiagnosing prostate cancer and overtreating prostate cancer, and this is probably true. However, it would be a real shame to ignore prostate cancer and to not continue to screen for it, because, as I said before, every prostate cancer is different, and we have to treat every man on an individual basis. A man who's 55 or 60 years old, who's healthy, who has a life expectancy of another 20, 25 years, if he's diagnosed with an intermediate or high-grade prostate cancer, he's not a very good candidate for observation, because it's likely at some point this cancer is going to become a problem for him and possibly even lead to death. For older men who have lower grade, lower risk prostate cancers, those are the men that we may offer watchful waiting or observation to. So it really has to be an individual basis. You can't just say, I'm choosing observation because that's what I've heard is a good choice. It's based on a few factors. What does the cancer look like under the microscope? What is your PSA level? What does your prostate feel like? Can we feel a tumor, or is this very early microscopic disease? What's the volume of the cancer in the prostate? How advanced is the tumor? And what are the patient's other comorbidities? What are the patient's other health factors? If a man is elderly with a lot of other health factors, medical issues, likely he's going to pass with something else, cardiac disease most commonly, diabetes and other problems. However, if he's very healthy and he just has prostate cancer, it may be worthwhile to treat him instead of choose watchful waiting.
Yeah, and watchful waiting is one, and it's one that a lot of men would be attracted to because the fear of the loss of virility that they imagine always comes if they have surgery would drive them to that. So when you talk about the other options,
one of our big problems with treating prostate cancer, and it doesn't matter which treatment you choose, there are some major side effects that men may have to deal with. Whether we're talking about the hormone therapy for advanced prostate cancer or radiation or surgery for early prostate cancer, there are definitely sexual side effects which men may run into. There are also possible urinary side effects which men may deal with. When it comes to radiation and surgery, these are the two most common treatment options for prostate cancer. Urinary symptoms afterwards, such as urinary incontinence, are symptoms that men may run into. When it comes to surgery, because of our advancement in our surgical technique, over the years, urinary incontinence has become less of an issue. A year after surgery, maybe 5 to 10% of men are still dealing with urinary incontinence. So over 90% of men will be dry or not deal with urinary incontinence a year after surgery. When it comes to erectile dysfunction, this is still a problem that we're dealing with. Even with our newer techniques such as nerve-sparing surgery, a significant number of men will still deal with erectile problems, erectile dysfunction after surgery. And this is very upsetting for a lot of men, especially younger men in their 50s and 60s who are healthy in the prime of their lives and still very sexually active. So there's definitely some fear associated with choosing a treatment for prostate cancer, and that's understandable.
And so you talked about younger men. I'm not sure, would prostate cancer in any way fall under the category of preventable cancers?
You know, with cancer such as bladder cancer and lung cancer, we know that smoking is a cause of these cancers.
Oh yeah, actually, yes, let's talk about all of those. Yeah.
Yeah, and
yes.
if people quit smoking early, they will significantly reduce their risk of developing a lung tumor or a bladder tumor. If they are developing bladder tumors from smoking and they stop smoking, their risk for developing new tumors will drop. If they continue to smoke, their risk for bladder tumors continues to remain high. We don't have anything like that with prostate cancer. We haven't been able to identify any particular cause where we can prevent the cancer. But we know that family history is definitely a major risk factor. If you have a first-degree relative, such as a brother or a father who developed prostate cancer at a younger age, that definitely puts a patient at a genetic risk for developing prostate cancer. And those patients just need to be screened more aggressively. We've got to keep an eye on those patients. One thing we've also found is that men of African descent are at an increased risk for prostate cancer when compared to other ethnicities. We're not exactly sure why. There's something genetic there. There's likely something genetic happening there. So men of African descent need to be screened more aggressively as well. We should start screening men of African descent at age 40 and yearly thereafter. In general, across the population, the general recommendation, and it depends on which group you talk to, there are definitely different opinions on this, but in general, screening is recommended yearly starting at 50. For men who have an increased risk, such as a first-degree relative or African descent, we start yearly at 40. My personal opinion is start at 40. If you have a negative screening at 40 with no other risk factors, we can check you again at 45.
Okay.
And if everything looks good at 45, then we'll start yearly at 50. And that's a reasonable approach. A lot of urologists agree with that.
And is there any research being done? Any new developments in terms of how to identify, to catch it, to see
screening? Yeah, screening. Yeah.
And PSAs. I mean,
sure.
Considering the debate over PSAs.
Indeed, there's a constant debate on PSA, and we've known for many years that it's far from a perfect test. We've been using PSA for about 30 years now. In the PSA era, as we describe it, we've definitely been able to catch prostate cancer earlier and reduce mortality from prostate cancer. However, PSA definitely gives us a very high number of false positive tests, meaning men come up with a positive test, but they don't truly have prostate cancer, which leads to a lot of unnecessary biopsies. And what we're finding out today is that there are some problems or risks associated with biopsies, such as infection. We want to reduce our number of biopsies while also maintaining our accuracy at diagnosing prostate cancer. So there are a number of tests that are constantly being looked at and developed to try to increase our both specificity and sensitivity for diagnosing and screening prostate cancer. There are a few urine tests. There's one very good urine test. It's called PCA3. It's a urine test that detects DNA in prostate cells that is more highly associated with prostate cancer.
Okay.
So what we do is we do a prostate exam for a man to push on the prostate some. Then a man will urinate into a cup. Some of the cells from the prostate will shed into the urine after their prostate exam. That urine sample will get sent to the lab, and the lab will run a very advanced assay, as we say. It's a DNA test to check for DNA that may be more highly associated with prostate cancer. This PCA3 test is a more sensitive, more specific test for screening. However, because it's such an expensive test, it's almost impossible to offer this screening test across the boards for everyone. So we can start with PSA, and if someone has a red flag with their PSA, we could either go straight to biopsy or have a discussion and have them do a PCA3 urine test and take it from there. But I think this needs to be done on an individual basis. And I think one of the problems with the debate is that, a lot of the people on one side of the debate are talking about screening a whole population and not talking about how we should talk to and educate each individual patient regarding PSA and screening.
Yeah. And I'm glad you brought up education, because part of what we want to do with the website is, in fact, what we want to do, the mission of the website is to educate people. And we've been talking a lot about, I asked about preventable cancer because we've been talking a lot about lifestyle, how lifestyles, the changing lifestyles are affecting people.
Yeah, I'll interrupt you for a second. We know that definitely lifestyle, diet, these things affect our overall general health. Probably our risk for prostate cancer as well. There have been some studies that show connections between diets that are high in animal fat and cholesterol smoking, some of these unhealthy lifestyles and their association with prostate cancer and all cancers in general. I think for men who are just eating an unhealthy diet, not exercising, smoking, these men are at an increased risk for prostate cancer.